the Mind Walk, and that I don't know about you, but that feels like a long time ago to me. So let's go ahead and get started. So we invite everybody to participate in a quick icebreaker. So feel free to chat in what brings you joy and work during these times. These challenging, difficult, one might say unprecedented times. I'll go ahead and give us 1 minute to do that. So I'm looking through the chat, I'm seeing a lot of people and human and family and friend connections. So that really resonates with me. I don't know about everybody else, but please keep those chats coming in. And I'm going to take us through our agenda today really quickly. So right after this, I'm going to hand it over to our IHI President and CEO, Dr. Kedar Mate, to do a quick IHI State of the State. And then after that, we're going to spend the bulk of our time doing an IHI Faculty Spotlight. And that segment will be facilitated by Allison Perry, our Director of Faculty and Fellows. And then after that, we're going to kind of go through two different projects that we're really focusing on right now at IHI. One is the maternal health outcomes, and we're going to hear from Dr. Audra Meadows and Shannon Welch. And then after that, we're going to hear about Project Echo from Christina Southey and Jessica Bearhorst. And then after that, Kedar is going to wrap it up for us. That being said, I'm going to hand it over to Kedar.
Thank you very much, Emma. And I'll just speak my what gives me joy in work, which is the opportunity to do so much meaningful work right now at a time when that kind of work is needed more than ever, with an amazing group of faculty and staff all over the globe. So it's really a pleasure, and thank you all for joining us today for this conversation. So Emma, I think you might have the control of the slide, so I just want to thank you for advancing. Perfect. So the first thing I want to share with all of you is it's a great privilege and pleasure to announce to all of you that Cynthia Bargineri has joined us at IHI as our Chief Operating Officer. Cynthia comes to us from Rush University Medical Center and System in Chicago, Illinois, where she has been the Chief Nursing Officer for several years, as well as the Chief Operating Officer, and most recently served as the Chief Transformation Officer for the entire system. Prior to that, Cynthia was at Baptist Medical Center South in Alabama, where she spent time as the Chief Operating Officer in the CNO. And then prior to that, she was at the University of Alabama in Birmingham in similar roles. So we're absolutely thrilled to have Cynthia joining us. Cynthia's overseen quality and safety work for Rush and for other systems that she's participated and worked with. And it's just been a joy to have Cynthia join our team and our leadership group, and to start helping us to become an even more successful organization going forward. So I'm going to give actually, Cynthia, I think Cynthia's online. And if so, let me just turn it over to you for just a couple minutes here to say hello and just share a few words of introduction.
Thank you, Kedar. Yes, I'm here. And if you hear something in a little noise in the background, I have blinds going up today while I'm on the phone. So my apologies if you do, but thank you all so much for such a warm welcome. Thank you, Kedar, for such a warm welcome and the kind words. I am very, very excited to be a part of this organization. One of the things that I chatted in about joy and work is the joy of knowing that I'm working for an organization that is doing good around the world. And, you know, one of the reasons I've said many times since I've been here, one of the reasons that I was so excited about joining IHI was because I am a big fangirl of IHI, having been involved with quality and safety for so much of my career, and having been a consumer and of all of the resources, both the thought leadership and the hard resources that IHI provides for leaders across healthcare across the world. So it is just a thrill to be a part of an organization that you feel like you've been kind of virtually a part of your most of your career. But it's also exciting to know that I am working for an organization with leadership and staff who are so committed to doing what's right and doing good in the world. And so I can't tell you how excited my joy in work is, just the fact that this is where I work today. So thank you all for being so welcoming and so warm. And I look forward to meeting all of you, and I look forward to learning how I can help support you in your success going forward. Thank you. Thanks, Kadar.
Thank you, Cynthia. I think you're all going to enjoy meeting Cynthia in Teams or Zoom, or hopefully someday in person. I know we're all craving those kind of interpersonal interactions, and I know we'll all have a chance at some point or another to work together with Cynthia and get a chance to learn from her as well about the experiences she's had as a running a hospital at a challenging time. So welcome, Cynthia, and thank you for those words. Emma, if you could go to the next slide. So when I started my time in the leadership chair at IHI, we did not revise our strategy wholesale. We had a strategy that we had been working on for some time, and it felt like the opportunity that we had in front of us was to just, in the midst of a pandemic, not to try to commit to a whole strategic revision, but rather to identify within our strategy what might be some areas that we wanted to focus our energies on and concentrate our efforts around. And these three were the three commitments that we made in those early days over the summer of last year. Foremost, a commitment to patients, ensuring that we get safer, more effective, and indeed more equitable care outcomes for our patients and families at this time. And we've been doing a lot of work in this area, notably around aging. As many of you have followed our work on age-friendly, work with nursing homes at this time, as well as work with various specific clinical conditions like pancreatic cancer and so on. So a lot of specific work on trying to improve health outcomes for individual patients and families in the first area of commitment. The second area of commitment is an area that we've been working on for some time, but you're going to hear a lot more about this in the weeks and months to come. And this is a commitment to the workforce. Never has it been more important for us to focus on the physical and psychological safety of the workforce, and indeed ensuring that the workforce is free from the harms associated with discrimination and bias as well. So as you can tell, there's an equity thread throughout all three of these dimensions of commitment. We have begun some work in our Leadership Alliance on physical and psychological safety. We've been working now for many years on joy in work and have some recent very exciting results from our work on joy in work with multiple partners around the world. And you'll see some of that roll up into a larger scale effort that we'll be launching in the next several months around workforce. And the third area is a commitment to society. And this dimension is about creating transformative capacity within our partner organizations to achieve the triple aim and change their sphere of influence, if you were. This is the way in which IHI multiplies its force. It creates a force multiplier effect in the world by actually creating partnerships and organizations that can create the kind of everlasting change that we seek. This is where IHI does its scale-up work, where it seeks to implement important changes at the scale of the whole problem that we're tackling. And some work that we're doing right now, which you'll hear about in a minute as I talk about some of our new strategic partners with Community Solutions, is starting to take an organization working in a completely different sector, in this case homelessness, to try to transform that sector using improvement methods that IHI has been pioneering in healthcare for some time. So these three commitments are what we have identified as our areas of focus as an organization as we build our future work. If you go to the next slide, you'll see how we intend to do that work. This is a favorite diagram at IHI of kind of how IHI works. And for some years, there's been a few minor changes to it, I would say, but mostly the concepts are still hold true. We started the center with innovating. Part of what IHI has made IHI strong and successful historically is that we have created new ways of doing our work, and we intend to continue to do that innovation work. We then work with a handful of partners, both our strategic partners, as well as with our Leadership Alliance and other partners around the world, to demonstrate results associated with those new care models and innovations that we created in the inner ring. When we get those results, we teach about them. We seek to increase people's understanding of what will produce those kinds of effective results for quality, safety, and equity around the world, and we educate through conferences and professional development programs and a variety of other courses that many of you participate in and that many of you teach on in your environments. And lastly, this outer ring used to be labeled dissemination. And we've changed it to describe, to inspire change, because a lot of what I think IHI does in the world is create movements for change, positive movements, social movements in some cases, to try to create the kind of change that we seek in the world. And if I see a little bit of what we've been doing right now with aging and with nursing homes and with other, with pursuing equity, it fits into this wider category of trying to inspire change in the healthcare ecosystem and in the wider social care and healthcare ecosystem overall. If you go to the next slide, I just want to share with you our group of strategic partners. We now have 19 strategic partners. These are relationships that help us to create those new innovative care models and help us demonstrate viable success stories from around the world. Many of you have relationship to these 19 partners that we have globally and around the world. You'll see that there are two that are highlighted here in red. These two are our two newest strategic partnerships. One is Tampa General Hospital. We've been working with Tampa for some years now on building their quality improvement capacity and skills, and they're now leveraging that for whole system transformation within their organization. We're pleased to welcome Tampa as one of our strategic relationships that's going to help us to grow and innovate further in the future. And the other is Community Solutions. As I described them a moment ago, this is a very different strategic partnership for us that we have had for a long time. Community Solutions is an organization dedicated to ending homelessness, not just in the US, but worldwide. And this organization has learned improvement methods and techniques from IHI and is now proactively applying those quality improvement methodologies to a different social problem, in this case, the problem of ending homelessness. And we're working together with Community Solutions and with some of our other partners, Providence and Kaiser Permanente and Trinity Healthcare, on how healthcare should be working on homelessness together. So you see the relationships that are building between our strategic partners to try to create meaningful models that will have the kind of effect that we seek in the world. On the next slide is our Leadership Alliance, if you can go there next. These are the 50 plus members of the Leadership Alliance for this year, 2020 to 21. A lot of very exciting members of the Leadership Alliance that also help us with the task of creating new ways of doing our work prospectively. And again, many of you will have had relationship to these organizations or may even be from them. On the next slide is our European Alliance. So we have a version of the domestic alliance in Europe as well. And we're starting to build towards creating a similar alliance in Australasia. So this very exciting group of organizations helps us to build towards the triple aim and create, again, new and dynamic models of change in our ecosystem. In the next slide is another alliance that we have, a coalition. It's called the Patient Safety and Quality Coalition. This is a little bit different than the previous two groupings. The previous two groups were by and large delivery systems. These are the technology partners to those delivery systems. Increasingly, the delivery of clinical services is a socio-technological phenomenon as we integrate humans and machines in our clinical environments. And by machines, I mean not just literal computers, but also the technologies that we wear and carry in our pockets. And these devices and technologies are going to significantly transform health and healthcare into the coming, has already significantly transformed health and healthcare, and will almost certainly do so more so in the future. These partners work with us through this coalition to help us bring quality and safety methodologies into their products and services so that they can better design those products and services to fit and operate within our clinical environments. And again, this is, I think, an important group of organizations to understand because they will help us in the future. I'm going to close with one last slide, I believe, here on an important program that we're working on, which you'll hear more about in the coming years, which is Pursuing Equity. This is some years ago now, faculty here, Ron Wyatt, Laura Botwinick, John Whittington, collaborated with our innovation team to produce a framework for how healthcare organizations can improve health equity, which is that wheel diagram you see on the right side of the slide. And then we prospectively tested that idea with a handful of healthcare organizations in Pursuing Equity 1.0, 8 original delivery systems that we tested it with. And now we have successfully launched the second wave of Pursuing Equity 2.0, which this should say launched in May 2020, which is when we did launch it. And we now have over 25 additional systems that have been working on bringing about equity through application of this framework. We will be teaching about this. So again, using that rings diagram, we created this framework in innovation, tested it with the first 8 organizations, now expanding the rings to the next 25. And we will be working on educational services that will accompany this, as well as the kind of large-scale campaign activities that might inspire change going forward. So with that, just as an illustration of some of the areas of emphasis for us, I want to just invite Allison Perry to join us here. Allison serves in a very important role for us. We haven't had this level of support, I think, for the faculty historically, but I just want to welcome Allison into this important role as the director of our faculty and fellows. And I know Allison will have a few words for us here. So Allison, over to you. And thanks everybody for the time.
Great, thanks, Kedar. I'm thrilled to be working more closely with the IHI faculty. I've been with IHI since the merger with the National Patient Safety Foundation, and I was with NPSF since 2000. I've been with NPSF since 2005. And I've also worked with the Anesthesia Patient Safety Foundation. So I've worked with many of you in various capacities over the years, and I'm so looking forward to meeting those that I have not yet had the chance to work with. The qualitative data from our recent surveys showed an interest in hearing updates on IHI, which you'll hear from faculty about 2 of our projects today. You said that you're looking for greater forms of connectedness, and it will be my responsibility to work on developing more of that alongside Kedar, Christina, Lisa, and Emma, who you'll see on this slide here. And I know you are likely familiar with all of them. We also heard that you're looking for more distinct points of contact, and I can be that point. You'll continue to have other points of contact, but if at any point in time it is not clear, I can be that person. In fact, I'll chat in my email address right now into the chat. And I also want to take a moment to extend an invitation to all of you to reach out to me. I'd love to hear directly from you more about what you value most about being part of this exceptional learning community. And also, I'd love to hear from you about what changes and improvements in IHI's approach to our relationship with our faculty you would recommend. So while we have this survey administered regularly, and we pay very close attention to that feedback, it's also nice to hear directly from you, either by email, which I've just shared, or by phone, to connect in a deeper way. So consider my virtual door to my living room open to all of you, and I look forward to connecting. Emma, can you advance to the next slide, please? Thank you. For today's call, we've invited 2 IHI faculty to share their experience and learning from 2 current IHI projects that demonstrate the results Kedar has spoken about in previous, in the Faculty Mind Walk in December. Dr. Audra Meadows will share her exciting work on integrating equity in an actionable way to improve maternal care, and Christina Southey will share her experience as a coach as part of IHI's partnership with Project ECHO and the Nursing Home Network Project. We also have 2 IHI staff supporting their work. Shannon Welsh and Jessica Bierhorst are joining us today. So now at this time, I think I'm handing it over to Shannon, who will introduce IHI's Better Maternal Outcomes project work. And Shannon, you can take control if you want to control the slides, or we can advance them for you.
All right, thank you so much, Allison. And actually, if you're able to advance, that would be great. So my name is Shannon Welch. I am a senior director at IHI. I've been working with IHI for a little over 2.5 years now, and I'm so honored to be on this call with you all today to want to introduce our faculty, Dr. Meadows, and then also provide you with a brief overview of the Better Maternal Outcomes Project. So just to begin us off, before I introduce Dr. Meadows, I want to share about this work that we've been able to be a part of. And so this work has been funded by Merck for Mothers. And when we applied for this work and as we've set out to do this, we've had a 2-track approach to it. And so on one track, it's focused on the Rapid Improvement Network, where we have been supporting national efforts to implement reliable evidence-based care for women and newborns around the time of birth, and specifically focusing on helping on uptake of the safety bundles as related to maternal health. And the other track of the work that I have been more closely working with is the Redesigning Systems with Black Women. And in this work, we have facilitated locally driven, co-designed rapid improvements in 4 communities: Washington, D.C., New Orleans, Detroit, and Atlanta, all at targeting at the interface of the healthcare delivery systems, the experience of those who birth, and specifically Black persons who birth, or as we've come to affectionately refer to them as context experts, and community support systems. And the goal of this has been to identify projects to test and scale up maternal supports, all while creating a learning system across all 4 communities. And I'm excited today now to introduce to you Dr. Audra Meadows on the next slide, who has been a big part of this work with us. And so Dr. Meadows is a birth optimizer and health equity champion, actively engaged in practice, research, and QI projects to optimize the experiences and outcomes of all birthing individuals. In her role as academic obstetrician, researcher, educator, and lead of the Massachusetts Perinatal Quality Collaborative, she centers equity action in the clinical setting through care design and safety bundle implementation. So Dr. Meadows, I'll hand it over to you.
Thank you. I appreciate that introduction. So I just want to take a moment with you guys to say hello. Thanks for having me, and to spend some time getting specific on action that we can do in health equity with the maternity care example. So next slide. So why is equity important? As you just heard also from your CEO, there is no quality without equity, and that's really important. And so as you engage in your teamwork with this in mind, it's important to always lay that foundation of the importance of equity and continually underscore it. And so if you go to the next slide, let's start with an example that we've given from our maternity care work. Next slide. Oh, you're there. Sorry. So we lead our teams to make the decision. So first, this work begins with making that decision that doing this work is important. And so I use this quote often to underscore that women are not dying because of diseases we cannot treat. They're dying because societies have yet to make the decision that their lives are worth saving. That's really important in our maternity care example, because what's happening when you see on the next slide is right now a crisis in America and across the globe, a human rights crisis. These numbers show that in the maternal health space, that our numbers of maternal deaths far exceed the rates of maternal deaths for other countries. Our numbers are rising in the United States when in other countries the numbers are going down. So we're an anomaly in that way. And so this is a crisis. And even if you look at these numbers separated by race, ethnicity, you'll see greater rates for women who are Black and brown, Alaskan Native, and American Indian. You'll also notice that even if you take out Black women and women who have the highest rates, for white women in this country, the maternal mortality rates are still ridiculously high and going in the wrong direction. And so this is a human rights crisis. As we work on this area, and as we put quality improvement to test in this area, we also want to make sure that we encourage teams to make the decision that equity is an important part of this. And so we have to look at this data in a certain way to bring that equity factor forward. Next slide. And this just shows you the racial and ethnic disparities and the pregnancy-related deaths in the US. And that tall purple bar shows the rates for Black women. Of the 700 deaths that happen every year, about 2 to 3 times, the rates that are, the group that suffers this 2 to 3 times more than other groups are that of Black women and American Indian or Alaskan Native. Next slide. So perinatal quality collaboratives are in a unique position to address equity by promoting equity in all aspects of improvement science. And so we ask our teams to take this approach as they address maternal morbidity and mortality. Next slide. And we will also show teams that this is squarely in our space. And so this graphic that's recently published by the Commonwealth Fund shows that where pregnancy deaths are occurring and morbidity is happening in these same spaces. It's just that death, of course, is the factor that we look at to indicate a population's health and health of women or birthing individuals in our society. This is happening in our spaces. This is happening in prenatal care. This is happening on our labor units, and this is happening in the postpartum space, but greater than half are happening during the pregnancy through that first week of postpartum discharge. And so with that known, this is happening squarely in our space. So we really lean in with our teams on that. And we also lean in on the idea and the fact that data has shown that more than 60% of these deaths, depending on the cause, are preventable. So with that, next slide. We also guide the conversations around equity and the impact of racism and bias on status, care, and outcomes, knowing that that stark disparity is present and has been persistent. Next slide. So in guiding that conversation, this is actually a national conversation. It's not just a conversation of the PQCs or our PQC. So if you go to the next slide, you'll see that this joint statement of the professional societies of obstetrics and gynecology has leaned in on a fact that is still not completely taught across the board in all medical schools in the US, is for one. And it's a discussion that's often been a sticky point, but one that has been proven in multiple areas of science, evolutionary biology, et cetera, that recognizing that race is a social construct, it's not biologically based, is important to understand because it's racism, not race, that impacts the healthcare, health and health outcomes. And counteracting the systemic and institutional racism that's pervasive in our country is an important part in doing this work in obstetrics and gynecology. And so I really appreciate hearing from you, your organization, or from our organization, IHI, that this is an important part of the work. So we go to the next slide. And when we have this conversation in our spaces and in the PQC space for perinatal quality collaboratives, we also talk about how understanding that our maternity safety bundles are a checklist, and they're often about applying that lens of equality. When we're talking about equality, and many of you have heard the words equality and equity used in current media right now in the lay press, and they're often used interchangeably, but they're actually very different words. And what we mean by approaching equity is, as we look at equality, it's the assumption that everyone would benefit from the same or equal support. So the maternity safety bundles that are checklists that we're applying across hospitals in America and that PQCs are working with hospital teams to apply, we notice that those checklists are about equality. They're about making sure that those foundations are there. But when it comes to supporting populations to attain their fullest potential of health, we need to think about equity. And what's beautiful about this slide from the Institute of Perinatal Quality Improvement is that when you look at the women standing on their box under equality, they're not all able to reach the fruit. They're not able to get to the goal. This is not a zero-sum game. And we often hear that also in the lay media and the press, that it's a zero-sum game to think about giving needs to others in order to meet equity. It's not. There are extra resources. And so I love that the boxes to the side show there that if you apply and bring those boxes over to women that need it or to birthing individuals that need it, you can help them attain their fullest potential for health. And so that's what we bring as an equity lens to application of these maternity safety bundles. On the next slide, I'll show you how we're beginning to get specific. So as we're having these conversations with teams about what to do in their spaces, we're starting off with raising awareness, raising awareness, and raising awareness. Why? Because we all know from the change management literature and conversations that culture eats strategy for breakfast every day. So we can have those strategies, but without raising awareness and without building those cultures of equity and building that concept that people want to attain a culture of equity, it's a little bit more difficult to get some of the actions moving forward. When we do, though, we first want to think about approaching and discussing differences by race, ethnicity, and then when you look at addressing those inequities, first by measuring them, right? So collecting and stratifying your data and monitoring those by race, ethnicity, preferred language, ability, geography, payer status. When you start to create equity dashboards to help monitor the progress of that by those metrics, and start to infuse quality discussions into maternal morbidity and mortality reviews, your case reviews on your labor unit, that's one set of ways to address inequities by measuring them. There's also pairing data with stories to lead to quality improvement action. And when we pair it, for instance, in the clinical setting, we do so by thinking about it on the levels that racism exists. So if you look at this schematic that talks about the 4 levels of racism, you'll see a dot, a color, and I use that just to sort of connect you on the next slide to what we're thinking about. And that is, there's systemic level of racism, there is the interpersonal, which is what we usually think about when we think about interactions of bigotry, so between other people. And then there's the internalized within the person, and then there's the societal policy levels. So one example of how we've begun education and training within Penquin is to think about this equity education through trauma-informed care for our opioid use disorder bundle that we've implemented, stigma and bias training. We've done that in person with our teams. We take a team focus for everything, virtual and videos. Also, we've engaged with Speak Up Against Racism training through a program from the Institute of Perinatal Quality Improvement, where they learn not only the racial bias education, but an upstander training on what are some methods that they personally can take on to be upstanders in the space of counteracting bias, and then also creating a culture of equity on labor floors. And so when you go to the next slide, we can show you that when you're at work, when you're in the clinical setting, for the clinicians on the call and for the clinicians and teams that you work with, and even in the other spaces that aren't specifically squarely in a hospital setting, we know that there are factors that influence the care experience and outcomes. So here comes those color dots. In the background, those societal factors with the pink dot, those are the areas where we can be related to levels of systemic racism. So that's by employment, public safety, housing, food insecurities, et cetera. The health system factors, the blue dot is there because those are areas where we think about where can we counteract the opportunity for, or grow an opportunity for us to counteract any areas of bias that could creep in through policies, financing, culture, et cetera. So those are those institutional level policies. The green dot is where that overlap of the interaction between the provider and patient occurs. So the patient with the orange dot, that's explained thinking about the patient in terms of their internalized levels of racism. And then the green dot is that interpersonal between the two. And we know that when time constraints occur, when there's stress and fatigue, when there are financial constraints, when there's a feeling of power dynamic, that we can actually find that those are when some of those greatest opportunities can occur. Next slide. So when you're in the clinical space and you're helping teams think through, this is an example of something you could apply. And so in this, we use a maternity care experience map. So we're walking someone through the entry into care from pregnancy, through their prenatal care experience, their inpatient admission experience, and their postpartum care and outpatient experience. And so there is an opportunity to apply actions for equity during this maternity care experience in many different ways. So similar to the graphic that was shown by Kedar early on, you see that we also agree that screening for social determinants of health and access to telemedicine would be a policy that would help to counteract some of those factors that are rooted in this ways that systemic and structural racism exists. Access, right? Access to care. We need to screen for those social determinants of health and then link people to community resources. That's a blue dot. That would be an institutional policy within that system. Risk screening in general and counseling using validated screens so that you eliminate that bias between a provider asking questions of a patient versus using those validated tools where a person either answers in privacy on their own piece of paper, bringing those results back, using a tool that has a scoring system that's been validated. Those are ways that can start to pull away and eliminate those biases that we might see between provider and patient by implicit or explicit experiences. Upstander training allows us to screen patients and to have conversations with patients in ways where even when others in our own space are making comments or doing things that we think could make a person feel devalued, having a lower level of experience, and say, hey, that's not, someone could interfere or interrupt in that experience. And I'll give an example. If someone is preferred language is different from English and the person is speaking in Portuguese, and then someone in the clinic starts to speak more loudly to the patient. We've all seen that. Well, that is a moment where you then want to sort of interrupt that interaction and say, can I help you with something or get an interpreter for you for your preferred language. And then that way you're using that upstandard training to make sure that the patient experience is elevated. And so there are other examples. I'm not going to go through each one of them, but the color dots just sort of show these are opportunities where the levels of racism where they exist could be counteracted or addressed or thought through as places where we could apply an equity lens to ensure that everyone, no matter what their background, cultural preferences, needs, et cetera, can be met in our clinical care systems. So next slide. And here's an example of when we've brought our patient teams to the Speak Up Against Racism training. We have, of the 40 some odd birthing facilities in Massachusetts, we've had over 35 represented in these trainings. And what we've found is as we help women, I wouldn't say women, I'm sorry, as we help participants, which I'm just showing that many of our participants have been women, as we've helped participants who are on the hospital side come to these trainings, we're helping them not to just think of creating a SMART goal around their aim statement for either implying a bundle or a SMART goal around their own actions related to equity. We're asking them to develop SMART-E goals. So not just a goal that's specific, measurable, action-oriented, relevant, and time-bound that we all talk about, but also make sure they're thinking about, are we being inclusive and are we being equitable as we're thinking about our goals? And then leading to our key drivers and our change concepts and keeping that at the forefront in the beginning as we set our goals. And so that's one task and tip that we've been teaching our teams through the collaboration with Dr. Bingham and the Institute for Perinatal Quality Improvement with the Speak Up trainings. And we do that also within the teams as we launch our bundles for our state PQC. Next slide. So I just want to say that what's important here is to think about, this is our house. We are here in the healthcare system in this space. This is an ode to Isabel Wilkerson for any of those in the chat who want to say that they're also reading chat. Like, the house represents maternal care and outcomes. This was built decades ago. It requires continuous work. None of us were here when it was built. We're heir to what is right or wrong with it, and to offer protection for consequences against inaction for our house. Our teams, we want to offer them tools to improve quality in their own transformational space. So whether they're the unit clerk or the nurse in charge or the clinical staff in other ways, or the physician, we want them to have tools so that with their own transformational space, they can help make a difference for the experience of the patient. So if you go to the next slide, I have some take-home points, which simply include: make the decision with your teams, drive them to make the decision around equity, raise awareness, raise awareness, raise awareness is so important to get you to shift the culture toward equity. Use data to identify disparities and inequities, and then pair that data with QI action, not only through training and education. You can help with mapping care experience pathways, whether it's stroke care, cardiovascular care, or the maternity care experience, and begin to have people help to identify these opportunities to implement equity-based actions with the QI improvement science framework. And so with that, we're improving our space so that we can all have a better experience for everyone. And this could then become our maternal care house. So with that, I'll turn it back over to your team at IHI.
Thank you so much, Dr. Meadows, and thank you, Shannon. It's wonderful to see how you've been able to build the culture around equity and build the quality improvement action opportunities. So we really appreciate you sharing your work. I'll now turn it over to Jessica Bierhorst and Christina Southey, who will share IHI's ECHO National Home COVID-19 Action Network. Jessica?
Thanks, Allison. It's great to see so many familiar faces, especially a colleague from Ochsner, Veronica. I see you there, so it's great to have you here. Also, I know many of you on the call have been a big part of this work as well, since this has been such a large network. So some of this will seem familiar to you, and thank you to Christina for joining us as well to share this. And so the ARC ECHO National Nursing Home COVID Action Network is, we can move to the next slide. Allison or Emma, whoever is driving. It's funded by the CARES Act, as a part of the CARES Act, and through AHRQ. It was working, so IHI has been working in partnership with the ECHO Institute, and so that is why many of us refer to it as the ECHO Project, but it is actually known as the National Nursing Home Action COVID Action Network. So the goals of the program were again to really create some national standardized evidence-based mitigation measures around COVID-19 for nursing homes. The goal of it on the IHI side was to provide curriculum, a 16-week curriculum based on nursing home content, again, in prevention of morbidity and mortality against COVID-19 in nursing homes. And in addition to that, create a library that could sort of live beyond this project. So the function of the library was to provide resources around the curriculum and other emerging topics to the training centers that were part of this nursing home network. So the training centers worked with the nursing home sort of pods or cohorts, as we called them. And so this also created a space for us to have a community with those training centers in order to have a network, a national network where we could share best practices around what was happening around COVID-19, since many of the practices were very emerging and the research moved very quickly as we moved through this project. So if we move to the next slide, please. So again, the key components of this project were working with the ECHO team. So the ECHO Institute has a model of all teach, all learn meetings where they already have an existing national network that we were able to leverage to quickly stand up this national network. And what IHI brought to this was the ability to provide this quality improvement lens to nursing homes and be able to help them using this COVID content, to prevent COVID, the spread of COVID, and apply quality improvement principles to it. And so we leveraged a group of coaches. Again, many of you here on the call joined us there to help these nursing homes and really create some sustainable improvement in the nursing homes. So tell you a little bit more about the curriculum. If we move to the next slide, I'm going to hand it over to Christina.
Thanks, Jessica. So, and I will mention that I am one of, I think, 70 plus coaches that are involved in this work in the QI space, and a number of them are on the phone. And so I'd please encourage them to chat in things that are similar or different, or ways in which your hubs have used some of these tools and approaches in a unique way, because I think it sort of gets at the nature of this project, which is that there's one sort of overarching model that's being customized based on the needs of the communities that we're supporting. So what you can see on the screen is sort of the 16-week curriculum content. And if you get a chance to read through it quickly, what you'll notice is that it really goes through a whole gamut of things around COVID, from disinfection, cleaning, screening, cohorting, all the way through to effective leadership and supporting staff, mental health and well-being, which is COVID specific, but also brings in themes that are sort of independent of that work as well. And the interesting thing about this work, personally, I've very much enjoyed it, being a coach for the cohort that I was supporting, is that you've got these content modules that are upwards to 20 minutes long. If you pay them at 1.25 speed, you can get them down to 12 or 13 minutes long at times. And then that is accompanied by some robust discussion within your cohort that sometimes is sort of a reflection of the content from the previous week, but oftentimes, at least for us, was a reflection of what the cohorts were, or what the homes were managing on a week-to-week basis. And so I put here on the slide, you know, next to the content that you can see there were some really key themes for discussion that were coming up that were, I think, reflective of what the homes were managing week to week. In the beginning, so my cohort launched in September, mid-September. We were the second pilot. So we launched a few weeks earlier than some others. For us, the first half of the cohort, our biggest themes around conversation were responding to positive cases, i.e., you know, a contract staff tested positive last week, and now we're going through our protocols around isolation, contact tracing, and the rest of it, and sort of bringing that up with their colleagues for suggestions or support. And then additionally, a strong theme was around trauma, resiliency, and well-being for staff. And really a number of homes sharing some quite heart-wrenching experiences they'd had in being in outbreak situations during the pandemic, and looking to peers and talking about what they are doing or what they might be able to do. And then interestingly, right around December, as you might expect, there was definitely a shift in attention and themes in our discussions, and vaccinations became a big part of the conversation post-December that persists. And now I think a lot of hubs are also having conversations around what do we do post-vaccination, and how do we start to reopen our home? How do we support people with long COVID syndrome? And how do we integrate sort of the post-vaccine world into our policies and procedures? Next slide. And with that, what you can really see is that some of the additional topics that have been woven in as part of this work are reflective of what we're hearing from the nursing homes. So this is intended to be something that is responsive, and I think I know that the team behind this work is really working hard to be able to pull together resources as quickly as possible. And I think the vaccination conversation, as you can see there, it's vaccines with a whole number of subtopics underneath. Definitely around logistics, and in the early days of vaccines, a lot of conversations around how do we just get these vaccines into arms within the home, but then definitely a lot of conversation around education, vaccine hesitancy, and how to support people in making a decision that's right for them. And then of course, staff mental health, and some specific conversations around COVID-19 resources for residents with dementia. Next slide. So interestingly, for a QI nerd like myself, which is how I come to this work, is that there is also a theme around quality improvement, right? We are there to help them with some of the core concepts and content around COVID-19, and we are also there to help them, hopefully, in learning some core strategies related to quality improvement within their sites that they can use now, but that they can also use moving forward. And the way in which the curriculum around quality improvement has emerged has been, again, very iterative and responsive. I think initially we thought we were going to have like a formalized curriculum around QI that would roll out, but it became evident very early on that that wasn't necessarily going to match the needs of each hub. So instead, what emerged was some suggestions around what people could cover in terms of week-to-week topics, but then a whole slew of sort of additional resources and really approaches that people could use around specific QI topics, but that were intended to be flexible to the needs of the cohort, that really got at using simple language. This quote is from one of my fellow coaches, and I apologize, I don't know who it is, but it really got at the heart of the matter. And they put in our chat one day on our weekly coach calls, the QI language is a gift nursing homes are not able to receive right now. And that was a recognition that the nursing homes were dealing with so much around COVID that asking them to do some of the mental work to understand what we were conveying around quality improvement with some of the jargon that we use, and that can be helpful in some environments, is maybe a deterrent for them to be able to pick up some of the useful tools and techniques that could help them now. So how do we take some of the ways in which we encourage small testing, some of the ways in which we encourage examining your process, using sort of staff conversation to get at ideas around improvement? How do we do that in the simplest ways possible so that anyone can really pick it up? And then a theme around just-in-time coaching. So I talked just a minute ago about sort of how we would have these discussions as a group. We would ask, questions of what do you guys, 5 people out of 20 indicated that you tested a change last week. Can someone unmute and tell me what you tested? And then as people were sharing what they were testing, there was some just-in-time coaching around how do you break that down into a small test, pulling out key things that they were already doing that linked to key QI concepts to show them that they already know some of this. It's just sort of clarifying some of that. So the coaches were asked to kind of get their creative hats on and find ways to take the quality improvement curriculum, some of the cooking tools, and then season to taste, because every hub was different. And so the way in which was going to work for the faculty in that hub, the homes in that hub, the nature of the discussion in that hub, it meant that the coaches had to be flexible right along with them. So next slide. And I won't go over these in detail. You can just hit the neck until they all pop up. I think there's 5 of them that'll pop up. These were sort of some of our for the top 5 things that came in when we went to the final session 16, to wrap up some of the key QI messages. And you can see they really are sort of general approaches around quality improvement to help people recognize some of the skills that they had learned that will carry them through now and into the future. And so a way to be able to try and capture, reinforce the learning that you have done, reinforce the natural ways in which you approach this work in a nursing home, and how that can connect to future skills that you'll use in the future. And with that, I'll pass it over to Jessica because we want to have time for our chat waterfall.
Yes. So very quickly, just to show you where we are to date on this progress, on this project, again, with the help of so many folks on this call and throughout IHI and the ECHO team. So in less than 4 months, we were able to enroll 99 training centers. 77% of those were academic medical centers. So we were able to launch 281 training cohorts that covered all 50 states and Puerto Rico. So next slide. And just to give you another look of where these nursing homes are, again, across the entire US and Puerto Rico. So close to 8,000 nursing homes participated in wave 1, and we've kicked off a second wave, which includes another 1,300 nursing homes. So really large scope of the nursing homes that we were able to reach throughout this project. Next slide. And then in closing, just kind of looking at what the impact is going to be of this, the sustainable nursing home impact. In the short term, we are hoping for better response to COVID-19, of course, so reducing morbidity and mortality to COVID-19. And in the long term, can we increase the leadership ability of the folks in the nursing homes? Can we create better use of the QAPI tools and really tie them to quality improvement as we know it? And then also making sure that we're using equitable principles to increase the appreciation of the lower level staff that are in nursing homes and really elevate the work that they do. And I think we've been able to do some of that so far, but I think there's a lot of work to do with that. So really great work that's been happening around the country, again, with lots of hands helping this work happen. And to close out, Christina wanted to do one of the tools that's really been great and being able to engage the nursing homes, and that's the chat waterfall, which many of you are familiar with, but I'll pass it back to Christina. So thanks so much.
Great, so thanks, Jessica. So again, this was a tool that was brought up by one of our coaches on one of our weekly coaching calls around how do we engage people in a way that encourages conversation, especially with quiet groups. And the chat waterfall was a tool that came up. So we're going to do it as a group as a way to sort of practice the use of this tool that I think hopefully you'll be able to go on and use in different scenarios as well. So I'm going to quickly go over the instructions and then we'll do it. So these are the instructions. First, you have to think of the first letter of your last name. So once you have the first letter of your last name in your mind, those of you whose the first letter of your last name is between A and M, you are going to answer the question that comes on the slide, but you're going to do it in a very specific way. You're going to look at the question. We're going to be silent for a minute. You're going to type your response, but you're not going to press send until I ask you to. So A to M, look at the question on the slide, type in your response, but don't press send. I'm then going to ask you to press send. You're going to press send. And then those of us who are in, well, you can also read the responses, but those of us who are in the last name group N to Z are going to read the responses that come through, and we're going to come up with a reflection based on those chats that we read. We're going to write those reflections in the chat, but we're not going to press send until I speak. So I'm going to bring the question up on the slide. I tried to do something general that I thought folks would be able to respond to, so let me know how it works, and we're going to try this out. So next slide. So if your last name starts with an A to an M, please chat in your response to this question. How have the themes or approaches in this work been similar or different to COVID-19 work that you've been a part of? Or answer a different question if you prefer. So you've got 1 minute, we're going to be quiet, and the rest of us are just going to sort of meditate for a moment while you all think and chat. Okay, that's probably roughly a minute. So if you can press send on those chats, and they're going to flood our chat, and we'll just wait for those to come through. And we're going to wait till all the pop-ups to leave so we can actually read them. So those of us, we'll give everyone about a minute to read through the responses. And if your last name is from N to Z, I'm going to ask you to take we'll probably give you 2 minutes. Hopefully that's okay. And take a moment to read through and sort of respond with a reflection based on what you're reading. And then I will sort of give you the go ahead when it's time to press send. And so I know that we're probably a little bit short on time. So if you want to hit send to those reflections, folks with the last name N to Z, please do. And that will be the end of our chat waterfall. So this is something that's gone over really well in our cohorts, and hopefully it's something that you might want to use in the future too.
Thank you so much, Jessica and Christina, for sharing a bit about what went into the development of this work. It's really been fascinating and an exciting journey to watch ramp up and launch so successfully. And I also think it's a true testament to our faculty who stepped in as coaches in such an innovative and adaptive way. So it's been very exciting. Kedar, I think I'll hand it back to you now for some reflections and a note about our upcoming call.
Yes, thank you, Allison, and thank you to everyone really who's presented here. I mean, it's just from Dr. Meadows' presentation, through what Christina and Jessica shared, to what Shannon led us off with. I mean, just a tremendous, you can see the breadth and scope and depth of the work that we are doing right now, that all of you are doing at the moment through the networks that we've created here together. You have our commitment to continue to bring these stories of the work, which is what this is, stories of the work that we all do every day, and the meaning and important impacts that it creates to you as often as we can, through every point of connection that we have with you, through newsletters and that you get from IHI, but also through these calls. And we hope we'll see more of you on them, and that we'll continue to bring these kinds of insights to you. It's always amazing to me to have a chance to dive in on a couple of projects and just learn a little bit about exactly what we're doing in these efforts and how powerful and important they are. So thank you to all of you for everything that you're doing around the world. And we look forward to continuing our conversation with you going forward. And I know we have one additional note here, which is that our next conversation will be coming up on June 3rd. This is our summer call. We'll be creating, again, opportunities for more of you to present and share your work with all of us so that we can learn together and advance and improve together. With that, I think we're done and right on time. Allison, is that right?
That's right on time, to the minute. Thanks so much, Kedar.
Take care, everybody.
Take care.